Alrighty, so we are at the 12:02 mark, and I think that's my cue to go ahead and kick things off. Thank you so much to everybody for joining us today. My name is Emily Kunish, and I'm the Senior Marketing Manager here at First Stop Health. We are a virtual care company serving more than 740 clients and about 750,000 members nationwide. I am thrilled to be moderating today's panel discussion, and we will be discussing virtual primary care and how employers can statistically improve employee health outcomes by implementing a high engagement virtual primary care strategy. A few things to note before we kick off today's event. This will be recorded and we will send it out to you sometime early next week in a follow-up email. And please feel free to drop any questions into the chat for the Q&A portion at the end of the presentation and panel discussion. We'll do our best to get to them. However, if we run out of time, we'll be sure to answer those in the same follow-up email. I am joined by two incredible panelists here today who will be representing an important voice in this conversation. Dr. Derek Baughman, a physician and researcher, will be walking us through evidence that virtual care can meaningfully improve health outcomes over in-person care. And Elena Gambon, our Chief Strategy Officer here at First Stop Health, will be sharing more detail about how First Stop Health deploys primary care and the perspectives of our employer clients. Elena, Dr. Baughman, would you like to share a little bit about yourselves before we jump into today's event?
Thanks so much, Emily. Glad to have you be moderating. I'll just give a brief intro, and then Dr. Baughman, who is the more important person on today's panel, would love to hear from you. My name is Elena Gambon. I'm the Chief Strategy and Growth Officer at First Stop Health. I've spent my entire career in employee-focused digital healthcare and have been in many different aspects of it, including operations, product, and growth. And one of the resume points I'm actually the most proud of is my public health degree from Berkeley, because it's enabled a thinking that is geared entirely around the science of patient behavior change and improvement in overall population health, specifically of an employer population. So you will hear a little bit of that slant from me today as we start to talk about engagement and utilization and the inpatient experience in a virtual care setting. So happy to be with you here today. Dr. Baughman, we'd love an intro from you as well.
Thanks, Elena. Good afternoon, everyone. My name is Dr. Baughman. I am a family medicine physician. I'm a medical director at an Air Force base in Louisiana. So I oversee about 5 different primary care departments, including pediatrics, OBGYN, of course, family health. And I also am a part-time telemedicine physician. I moonlight with another health system out in Pennsylvania. And so I do telemedicine about 3 nights a week and really enjoy that work as well. It's given me a lot of insights onto the research side. My research has been in telemedicine quality measures, which we're going to touch in detail about in just a minute here. And what that has allowed us to understand more about where is telemedicine useful and how can it be applied. I've been fortunate to be able to present this research at multiple national forums. We were just out at the American Telemedicine Association last month. So getting a lot of great feedback and interest in continuing our work. And in the fall, I'll be starting an informatics fellowship. So looking about how to kind of integrate telemedicine on the broad scale. So looking forward to chatting with you all here briefly about our research.
Well, as I mentioned, 2 amazing panelists joining us. So the format for today's event is a combination of presentation, panel discussion, as well as a Q&A. We'll be talking topics including statistical evidence that virtual care can outperform in-person care modalities. We'll review the current state of primary care and we'll point out some areas for improvement. And we'll also discuss the merits of virtual care and engagement strategies. And lastly, clinically, how virtual primary care can address chronic disease and mental and behavioral health. The question posed on this slide is one of the 2 questions we will be answering today. Is the quality of virtual care and in-office care comparable? And so what? Why should an employer or benefits consultant pay attention to the caliber of care delivered virtually? We're going to start off with this first question, and I'll turn it over to Dr. Baughman to review his research that will help us answer it. Dr. Baughman, over to you.
All right, everyone. This afternoon, I'm hoping to provide you some evidence that shows you how telemedicine can provide quality of primary care. So what our team did was we understood that quality is tied to value. So it's hard to place a value statement on telemedicine without assigning some quality, some objective evidence of that quality. So I'm introducing some of the National Quality Forum standardized measures here. Some on the call may be familiar with these measures. These are what are known as HEDIS measures, and these are tracked broadly in healthcare. These are very well known throughout the industry, and these are represented widely by multiple organizations. So you see on the slide that 75 different stakeholders are involved, and that's everyone from the pharmaceutical industry to clinicians to insurance companies, government, et cetera. The important thing about standardized quality measures is that once these are endorsed by a national organization like this, these are how we are able to compare the quality of care that we deliver across different care venues. So in our research, these measures were really important to be able to compare objectively telemedicine and office care or office-based care, traditional care. And what our team we use these standardized measures that are specific to primary care. So different specialties have different sets of HEDIS measures. And we, of course, used the ones for primary care. And there are several measures that are specific to those actual, the primary care itself. So we can move on to the next slide. And our team took these measures and we sort of bit these off in pieces. And we started this research over the past 5 years, and we first looked at one of those HEDIS measures, which was A1C, and maybe folks on the call will understand that A1C is how we can measure the success of treating type 2 diabetes usually, but also type 1. And this is also a HEDIS measure. So on the far left is our very first publication that we did back in 2020 that we published in JAMA Open, where we just said, hey, can we do one of these measures? And we were able to successfully compare telemedicine and office cohorts and spread those apart and be able to see, hey, if you ordered a test with telemedicine, were you equally as likely to be able to get that test completed if you're in the office? And we actually found that those were comparable. And so from there, we were able to experiment with additional methods using different HEDIS measures. So the next paper on the screen is about use of telemedicine versus office quality performance in back pain, for low back pain. We were very surprised to find that telemedicine actually had a better quality performance in this aspect, because you'd think, well, you should just order the x-ray to be safe, but that wasn't the case. This also led us to experimenting with a blended cohort of telemedicine and office care, which we looked into BMI screening, and that was also in the spring of 2022. And this is where we started to realize, well, there may be some benefit to blending telemedicine and office care, but it helps us understand where are the borders of telemedicine, where it can be effective, and then where is the care, of course, comparable. So all of that led to the culminating project, which was just published in JAMA Open in September of this past year, which was where we took 16 of those measures all together using the methods we built on to be able to compare office and telemedicine based care. So on the next slide, I'll show you what we did in that project. So you're seeing on the screen is a flowchart, and this flowchart tells you kind of the hierarchy of steps that we did to be able to successfully measure this quality in between the two cohorts, which would be office only patients and then patients who are exposed to telemedicine. So I'm starting at the top left, the gray box that shows you the number of patients that were in the study that were primary care. Now, we filtered these by only primary care patients, so this excludes surgery patients or anything else but primary care. We measured those 500,000 patients over the pandemic timeframe, so starting when the pandemic was announced through the end of November of 21. And then we used software to be able to divide those cohorts into patients who had only office visits so that we could compare them to the patients who were exposed to telemedicine. So either had telemedicine visits or a combination of office and telemedicine. The green boxes are showing you how we actually built those HEDIS measures within this program called Slice or Dicer in the EPIC electronic medical record. You can see that there's specific inclusion and exclusion criteria that bill each of these HEDIS measures. So for example, like colon cancer screening, there's different tests that you can do to meet those criteria. And there's exclusions as well. And eventually we were able to boil those down into essentially a percentage or a rate where we could compare, and that served as the quality performance, where we could compare the office rate to the telemedicine rate. And we can move to the next slide. So I want to highlight here that in this, across these studies, we weren't inventing these quality measures. We were using very well-established national standardized measures from the National Quality Forum. And what I'd like to add to this slide is although there's 22 measures in the data set for primary care, across the 5 publications that we've done, we've evaluated about 86% or 19 of those 22 measures, which is really important for kind of painting a picture of quality. So on the next slide, I'm gonna show you what we found. And this should give you some insight onto how telemedicine quality is comparable. So in our results, we broke these, we broke the clinical effectiveness down into 2 sort of frameworks, which was, 3 different frameworks, which was based on clinical intervention type is what we called it. So we had measures that are either medication-based, and then we categorized the other measures that were testing based, and then others that were counseling based. So what you're seeing is a chart on the right there. That's from our results. And you'll see in the top section that are highlighted green, those are the medication based HEDIS measures. And what our results showed was that the office only cohort actually had modestly better, and I say modest because it was only about 1 to 7%. If you look on the far right, the absolute difference in percentages between the telemedicine and office was slightly better for office. And these would be medication-based measures that would be like if you have cardiovascular disease, are you on a cholesterol medicine, or are you on a beta blocker? It was modestly better, but you can see on the far right, two of the 5 measures were not statistically significant. In other words, that means that it was indifferent from telemedicine care. So that's for medication type measures. Now for testing based measures, you can see in the middle portion there, they're highlighted in the orange. These would be things like if a diabetic patient being compliant with their A1C testing, or is the blood pressure controlled? And in all of these testing-based measures, surprisingly, we found that telemedicine-exposed patients had moderately better performance. So the range was in the 5 to 10% better than office-based care. And then lastly, in that counseling-based measures, now these were all things like types of cancer screening. So you can see all the different types of cancer screening that are recommended in the HEDIS measures. Also, tobacco prevention, vaccination, and what is very hot topic now is depression screening and depression care. What was very interesting is that across all of these counseling-based measures, telemedicine was moderately better or considerably better, we called it. And if you look at those percentages, better than office is about 5 to 17% better. And all those were statistically significant. So if we go to the next slide, I would like to pull away some takeaway points for y'all. And so first thing to think about is, well, if I'm a company and I'm going to think about having telemedicine for patients that I'm caring for, what's going to be the effect? We argued in our research that telemedicine exposure is probably going to augment your value-based care. And value-based care is certainly based on quality. And why we think it augments the care is because you have more opportunities with telemedicine to promote those quality performance activities that are going to improve your patient or your population's health overall. And the next question we thought about was, hey, what's the risk if I'm going to be starting to use telemedicine in patient care? Well, and we're arguing that it's a low risk for a negative impact on your quality performance because we've shown it here in our research in a large population. But the reward here is high, and especially for employers who are thinking about how can I keep my populations healthy. So adding telemedicine, again, because it ties into point 1, where it probably increases the opportunity that you get to help that care and promote that quality performance. And then thirdly, the real benefit of here with telemedicine is that you can increase that provider capacity because you're having all this more opportunity to treat, but it also is going to sustainably probably increase your quality performance. So these are the real three big takeaways. And if you look on the next slide here, we have a summary slide of all 5 studies, and I won't dwell on this slide, but for folks interested in questions about specifics on how this research has helped, these are the specific areas. So these are, again, I'd like to highlight that we've looked at 86% of the HEDIS measure set for primary care. And here's what the research is showing, is that for most things in primary care, you can do telemedicine as good and maybe better. So this is a really important concept that we're excited to keep researching, and look forward to some of the questions from the audience moving forward.
Well, thank you so much, Dr. Baughman, for this amazing information. It was truly insightful. I'll ask the audience to keep this in mind as we shift into a macro discussion around why these findings are so important with our panelists. Elena, I'm going to turn the first question over to you. At a high level, why should an employer or broker care about this research? In essence, so what?
Awesome. Well, first, I just want to say, Dr. Baughman, thank you for so clearly articulating the incredible work that you've done. And I want to just say that I really appreciate how the industry at large has prioritized a lot of research in this area, because it's one thing to innovate and to expand access, but if you're not doing so in a way that is statistically, clinically impactful, we're not necessarily doing right by patients. So I really, really appreciate all the work that you're doing there and sharing it with us. But I think, to answer your question, Emily, the so what is really rooted in the fact that primary care that is delivered virtually is trying to solve a problem. We know when primary care is used, meaning when patients actually go to a primary care physician, and when it's delivered effectively, it is an incredibly powerful tool to mitigate risk to both healthcare outcomes as well as cost. In fact, there is research that shows that patients who use a primary care doctor regularly incur 30 to 33% less per member per year costs to the plan, and therefore to themselves, because they're getting more preventive screenings, they're using less unnecessary ER services, they have 19% lower mortality and morbidity rates on the whole. But the problem is, so very few patients actually see a primary care physician. In fact, latest research shows that 60% of adults in the US on commercial plans have had no primary care in the last 2 to 3 years. And that's really a function of high costs, a lot of patient inertia, patients maybe not knowing exactly when and how and why it's so important to see a primary care physician, and the fact that there's tremendous provider shortages. In fact, 1 in 3 people in the US live in a health professional shortage area, meaning there's not enough supply for potentially the demand. So if we think about a virtual solution that can close that gap, that can turn that 60% into 30% or 20 or 10%, then that is a really meaningful strategy for reducing barriers to care. And if a large percentage of patients are then receiving primary care virtually, as an employer and as a consultant, you need to know that the quality and caliber of that care is equal to or exceeds the quality or caliber of that in-person care. And so it matters because this offers evidence that allows an employer to confidently make a decision to deploy a virtual care strategy in an effort to close gaps in prevention care and improve access for their employees and the family members that rely on those employees.
Thank you so much, Elena. Dr. Baughman, if we could stay on this trend for just a moment, why exactly is it so important to an employer that a patient see a primary care physician? So what's going on in that clinical setting that they don't necessarily get at a retail clinic or an urgent care or even at a specialist?
Yeah, thanks, Emily. From an academic standpoint, we know that continuity and comprehensiveness of a PCP has certain outcomes, certain impacts on outcomes. This is very well studied, and this has real, and of course, employers are going to know how does this impact cost, and those studies have been done too. So what you're getting differently from a PCP that you wouldn't get from just an urgent care or retail clinic is you have a clinician who is continuously and comprehensively treating a patient and understanding and preventing disease. And I think that's the real value that gets missed Because if we think about things like heart disease, cancer, diabetes, these are the commonest diseases in the US. And most of these diseases are either manageable, preventable, or they're curable. And you're not going to get those addressed in a retail clinic or in urgent care. And this is where I'm going to bring it back to our research. It shows that even with telemedicine, PCPs can meet those goals of managing, preventing, or curing these diseases with comparable quality. Whereas you can screen you for cancer, they could help you stop smoking and treat mental health or chronic diseases. And the compounding effect of that and the preventive effect of that, we can't even measure that. So we don't even know the benefit long-term, but the fact that you can do it via telemedicine is pretty impactful. So to sum this all up, it's really prevention here. That's the benefit of the PCP. And that's why the employer should care about this, because the analogy that I use is that the reason you go and get your oil changed regularly in the car, you're not going to feel like you need to do it, but that maintenance is preventive care that keeps your car on the road so that you're not breaking axles and you're actually saving money in the long term. And you can't measure that. But moreover, that mechanic might find something that wrong that could be life-saving. So that's why we screen for cancer, and that's why we prevent disease. So prevention and continuity it's invaluable.
Thank you for sharing. That's a great anecdote. We'll move over to the next slide. So if virtual care is equal in clinical caliber, how exactly does it help improve utilization? Elena, I'll pass this question over to you.
Yeah, so I sort of alluded to this in my last answer, which is that virtual care is sort of inherently closing a gap in access. And I really can't stress enough that if you are implementing any type of solution in employee benefits package, if it is not used, it might as well not be there. And so there's really two components to your answer, Emily, around why virtual care is so good at improving utilization of healthcare in a positive way. And the first answer is really around the nature of virtual care itself. And the second is around what I believe the way that we've designed our virtual care program to go above and beyond. So if you start with just the innate qualities of virtual care that promote utilization, really the first piece is that it is simply so much easier for the patient. And we know that one of the primary motivators of behavior change is how easy the activity is. So think, no transportation is required. There is a lot more flexibility around when and how a patient can access that care. No cost is usually required to actually get to that virtual visit unless there's some sort of fee associated with a virtual care visit. And so it's typically a much easier, lower costing solution for when someone wants to receive care. The way that we deliver it is really, we think about virtual care as a true virtual medical home. So we are hyper-focused on engagement and follow-up to the extent that we have designed our entire business model and product and organizational goals around utilization above and beyond what a traditional virtual care solution or even care delivered virtually by an in-network provider would achieve. And some of the things that we do differently that enable that are, number one, speed to access. So we're striving to get patients in to see a virtual urgent care provider in under 7 minutes, sooner appointment availability for scheduled care with primary care MDs and DOs and counselors. On the urgent care side, availability being broad matters a lot. So 24/7 access to a licensed MD or DO. And on the scheduled care side, early morning, late evening, and weekend appointments make all the difference in terms of access and utilization. And just more time with the patient, right? Making that feel meaningful, establishing trust. The second thing that we do that's a little bit different than most solutions is we are hyper proactive around getting a patient into the first visit and then following up. So we use and fully fund and deploy an engagement program that is persona and demographic based, customized by client. And the follow-up that we provide is very focused on clinical adherence, so that even once a patient's come in to their first visit, we want to make sure that we are meaningfully moving the needle on a closing of the gap in clinical follow-up requirements, like if someone needs a colonoscopy or making sure that they're picking up their medications that they then take. And then the last piece here is around our business model. So we are a capitated revenue structure. We also deploy performance guarantees around return on investment and utilization, meaning we are at risk on the value-based chain of care. We are at risk for the services that we provide and the success of those services, which has enabled us to achieve 45% utilization across our book of business. And on the primary care side, a statistic that I am exceedingly proud of is that 70% of patients in our primary care are new to primary care and haven't seen a doctor in the last 12, 24, 36 months, and sometimes ever, which means we're not just getting utilization, we're getting the right type of utilization. The people who are otherwise skipping care and at risk for greater issues in the long run, and not, as Dr. Baughman said, getting routine prevention, which is so imperative.
Thank you for sharing, Elena. Dr. Baughman, I'd like to dig a little bit into the patient experience here. I think we have a good sense on how virtual care can enhance adherence to prevention, but how exactly does virtual care enhance the ongoing management of chronic issues?
The short answer here, Emily, is touch points equals trust. So medicine's made a lot of progress in screening and for managing chronic disease. And this is bread and butter for the PCP. We do this every day. And the goal of the routine check-ins with PCPs is that you get to build this relationship with patients, and that this relationship is going to help patients make better choices to live longer, to live healthier, and manage that chronic disease long term. So what we found in telemedicine, and regarding answering your question about how virtual care enhances this adherence, is telemedicine is particularly effective at chronic disease management, especially in cardiovascular disease and diabetes. And these can be some of the most costliest diseases for employers or in payers. But more importantly, this can be quite costly for patients in their lives. And being able to handle that over telemedicine effectively is huge. What I'd like to make a note about in our research is that if we think about telemedicine as a whole and virtual care being able to really enhance that ongoing management concept, is even if you think of the spots where our research showed that there was modest, better improvement with the office, specifically in the medication, starting the medication kind of a thing, it was modest at best, like less than 5%. So what we're really finding is even in those boundaries of where we think telemedicine may be, that there's really still comparability in a clinical aspect. So if I'm boiling this down, the main way telemedicine is going to enhance disease management is through follow-up and engagement in that telehealth. Because if you have lots of continued management, you're going to have more touch points, more trust. That's going to help build that patient relationship. And for the PCP and the patient, this happens not just in the encounter. This can happen through in between visit encounters, through patient messaging. There's a whole telehealth component to that includes telemedicine. But this increased access is the real magic here, because it increases the access for patients to promote those health outcome improvement opportunities.
And so from your perspective as a physician, Dr. Baughman, how do patients, especially those that are used to in-person care, respond to virtual visits?
Yeah, so I'll give you an anecdote in a minute. But besides my opinion, this has been reflected pretty strongly in the literature. So research shows that patients find high satisfaction rates with telemedicine, and they like it because it's convenient, it engages them to be more adherent in their treatment plans, and it cuts down travel costs. There's a host of other reasons, but we're not just making this up. This is a fact that patients like telemedicine. And I'll tell you, in my personal experience, I've just had so many positive reports from patients as a telemedicine physician working evening hours. And again, this is an access point for patients. So I won't share a specific patient, but I'll share a category of patients. And I see a lot of these after hours, upper respiratory infection and urinary tract infection patients. And when I see these patients, they tell me, thank you for having these evening hours. Otherwise, I would not have been able to do this appointment. And I get, you get the night shift patients, you have kids who have 3 or 4, or you have parents who have 3 or 4 kids in after school programs or sports, or sometimes you get these older adults who say, I know what a UTI feels like. I think I need antibiotics, and, you talk it through, and sure enough, they would. And I always respond with something like, oh, sure, patient, I'm glad to help you. It's my job. But when I really sit back and reflect on these things, and to answer your question, as from the clinician perspective, is these are the moments where I realize how valuable I am as a virtual clinician, because I am saving these patients over and over again from the 3-hour ER visits that just going to wind up in them getting their prescription anyway and not admitted, and perhaps getting stuck with a copay and frustrated Googling and all these other things. These are what patients tell me. And this, I think, for clinicians is what makes the work fulfilling. So I think this is for an employer thinking about first stop health, you have to think about the physician burnout and the physician well-being. And to be able to consistently have these kind of experiences with patients where you don't have to worry about the volume of patients you're seeing in your 10-minute encounters. You can spend 30 minutes, you can spend 60 minutes if you need to. Those are the kind of moments that for a clinician, and the experience with the virtual care is very valuable from our side. But what I've seen doing this now for a couple years now, is that patients don't even know how to express how valuable they find it. And so, and I'll reorient this back to the research, is that this is why telemedicine is valuable, because in these experiences, you can augment your care capacity for the patients who need it. And what's the side effect? Probably improving your quality of performance.
The ease of access is absolutely huge. And thank you for sharing the personal anecdotes. So we've talked a lot about the role primary care plays in physical health, but we know primary care physicians are incredibly impactful when it comes to mental health care as well. We know this from our own programs, where we are experiencing about 1/3 of patients talking about behavioral health. Statistically, 50% of adults will be diagnosed with a mental illness in their lifetime, and that can show up in the primary care setting. And if a patient has a chronic disease present, they are actually 3 times more likely to develop a mental health issue. So Dr. Baughman, as a PCP, what are your experiences with and thoughts on helping patients with mental and physical well-being?
I'm glad you're asking this question, Emily, because as a family doctor, mental health and psychiatry is a part of our practice. But I think with telehealth, and especially in light of pandemic, it has become a keystone of my practice. I would say probably a good 40-50% of what I do on a day-to-day is mental health related. And I'd like to give you another category of patient examples, but I think from the ability to be able to help patients in this with mental health is huge. And from what we know moving forward, this need is only increasing. And so I think it's important for employers to know that the need for behavioral health care is increasing, and family doctors are really filling a gap here, because we're practicing it all the time. We're getting good at it. So I'd like to share, I'm thinking of at least 5 young adults that I manage regularly for mental health related problems. And these come to mind because these are patients that I see, I've had to see frequently, and they stick out to me. And this is mostly anxiety and depression related patients. And many of these patients they're either in school, or they don't have time to seek traditional behavioral health care, for example, like outpatient counseling, or being able to follow consistently with a psychiatrist. and many of them have a distaste for behavioral counseling, and many of them have I hear the story of, oh, it's a 3-month or it's a 6-month wait list to see a psychiatrist. So again, this kind of flexes back to PCPs becoming practicing psychiatrists. So I describe the relationship with these young adults who are struggling with behavioral health as a digital rapport. There is nothing more unique than being able to be inside a patient's home, one-on-one, in an encounter. That space is only created in a telemedicine encounter. And I think it is so uniquely adaptable to the mental health community, because there's some sort of openness that I found that patients are able to communicate their problems more effectively. It helps me diagnose it quicker, and it also allows them to trust me in order to have this follow-up to titrate medicines and such. So I call this digital rapport. And this opens the door to not just help their behavioral illnesses, but it builds this trust needed to try other medical options that haven't worked. And I mean, I'm talking a pretty broad breadth of mental health disorder. Like, I have diagnosed bipolar, ADHD, severe depression. I'm able to manage these problems on an ongoing basis. I've never actually met these patients in person, but I have this digital rapport where I can meet them every week or every 2 weeks if I need to titrate their medicine. And many of them, I'm thinking like these 5 patients that I have, and I see them probably like at least once a month, and they are doing better because I think of that frequency and that continuity that they're having in that care that is only made possible in this like intimate environment of trust and via telemedicine. And I think the hit home point here is that as these patients become more comfortable using the patient portal, and I'm able to make these medication adjustments, order labs, answer questions, this just continues to enhance that physician-patient trust. And I'll bring it back to our research that I opened up with. I'd like to just comment that, remember, telemedicine and depression screening, it actually performed better. For the researchers on the call, we did a regression analysis, and patients with telemedicine are actually more likely to have depression screening. So I think it's not just my experience or thoughts, it's the patient's attitude, it's the evidence. So we have real outcomes that are doing better as we continue to help our mental health patients.
Yeah, I see ease of access becoming a huge theme here. Just the frequency and the continuity is incredibly important for those patients. Elena, I do have a question for you about how are employers thinking about using primary care as a mental health enhancement strategy?
Yeah, and I think I would just want to echo so much of what Dr. Baughman said in terms of some of the discrete lines of work that a primary care physician can do in the essence of mental health. But for those in the audience that aren't aware, First Stop Health provides not just virtual primary care and virtual urgent care, but also virtual counseling. And that virtual counseling really takes the form of short-term cognitive behavioral therapy. So thinking, talking to your designated licensed counselor who has experience in your domain of need. And in fact, almost all of the clients who have partnered with us for virtual primary care have opted to also include virtual counseling. The two solutions are really a masterful pair, because you can imagine that there are some patients who will route first to primary care and then in essence need some sort of counseling, or vice versa. And they sort of pair well together because you have a medicalized sort of treatment modality of a mental health issue and then a counseling-based treatment modality of a mental health issue. But speaking specifically about primary care, there are a few discrete ways in which primary care is inherently on its own a mental health solution. And to some extent, this is just a repeat of what Dr. Baughman said. But in our solution, there's really 4 main things that we do in primary care in this regard. So the first is medication management. We prescribe non-controlled psychotropics, such as an SSRI or an SNRI. And for those who are more familiar with the medication names, things like Prozac, fluoxetine, anti-anxiety, antidepressant medications. And we actually find that primary care prescribes more sort of low acuity mental health medications than most psychiatrists, because so few psychiatrists are in network patients also are finding that there is a dearth of psychiatrists. There just are not enough to meet the demand. So most patients will end up in a primary care setting, and that certainly is the case with us as well. The second is that a lot of mental health issues manifest as a physical condition. And so then they are often treated and detected in a primary care setting. For example, weight fluctuations, a lack of sleep, even stomach aches can often be a symptom of an underlying diagnosis of extreme stress or anxiety. And so when a patient is coming into us in a primary care setting, often they may not even know that they're dealing with an underlying mental health issue. And it is through diagnosis and multiple touch points that we're able to help them understand that they've got more than one thing going on. The third piece is that routinely, when we see patients in any primary care visit, we are doing PHQ-9 and GAD-7 screeners, meaning we are screening routinely in a very metriced way for not just the existence of a mental health issue, anxiety and depression, but the improvement of it over time. And that's just to kind of take us back to what Dr. Baughman mentioned at the end of his commentary, which was that we know that patients in telemedicine statistically receive more and perform better in terms of receiving those screenings. And then lastly, I'll say our primary care includes sort of a wraparound of navigation. And what I mean by that is we know there are limits to what virtual care can do. We can't yet do virtual lab draws. We can't yet do virtual mammograms. And so if and when a patient needs in-person care, we have the capability to steer in-network towards the highest quality, lowest costing option available. And sometimes that means a patient needs a substance use rehabilitation center. And sometimes that patient needs an in-person relationship with a psychologist. And if and when that does occur, not only are we able to manage a lot of that virtually, but we can then steer the patient to the right mental health resource that is going to optimize the use of their benefits and as well as the quality that they're receiving. So it really is a true mental health solution as much as it is a physical one.
Thank you both for sharing. It is important to acknowledge that there are limits to what virtual care can do. So Elena, a question an employer might ask is, sure, virtual care is increasing access and utilization, but is it just duplicating spend or creating unnecessary utilization? Meaning, is it actually replacing in-person visits and impacting trend?
Yeah, this is an incredibly important question. So the first thing I want to just level set on is we believe, and we believe you should believe, that primary care utilization is always a good thing. If a patient is seeing a physician and getting their preventive screenings, they are impacting the health of themselves and of the population in which they belong downstream for the better. And so we want to tolerate short-term increases in preventive care costs for the benefit of long-term care management. However, there have actually been a number of studies that show, in fact, the care that we receive virtually is not duplicative, meaning it actually is replacing the need for in-person care in many circumstances. Epic Research produced an interesting study that demonstrated over 75% of commercial patients out of a cohort of, I believe, about 4 million patients that they surveyed clinical data for, showed that over 75% of those commercial patients who had a virtual primary care visit did not need any type of in-person follow-up after that visit for a period of 90 days. And if they did, it was usually for some sort of diagnostic or some sort of completion of a preventive exam, meaning that the virtual care itself was clinically competent. That patient didn't need to then go to an urgent care and see a doctor to confirm what the virtual care physician had done. And some people might ask, how is this possible? I'm used to going to a primary care physician and they lay hands on me and they listen to my chest sounds and they look in my ears and they look at my eyes. How can you physically examine someone completely virtually? And what I always like to do is encourage people to think about, okay, if you're in an in-person primary care visit, there are really three things happening. The first is that you're talking to the doctor. The doctor's asking you questions about your symptoms and your medical history and how you're feeling. And most of that visit is communication. The second thing that's happening may be that they're laying hands on you. So palpating lymph nodes, maybe looking in the eyes and the ears, listening to chest sounds. And then the third thing that's happening is follow-up recommendations. So think recommendations or prescriptions for medications, exercise, change in diet, or a diagnostic that is actually typically done, in a later visit or at a lab down the road. And statistically, the most important part of that visit is the communication and the adherence to the follow-up. There is very little evidence to show that there is a strong impact on mortality or morbidity when patient is being touched by a provider. And most of the good that is done in primary care can be done virtually and done well. So it is really the counseling-based metrics and the testing-based metrics, those HEDIS metrics that Dr. Baughman explained, that are in fact proven to be more impactful in a virtual care setting. That's what we want to focus on, and that's what's being done well in a virtual care environment.
Incredible. So another argument that an employer might make is, why not just use virtual care delivered by my in-network provider? What is exactly is the difference between them?
Yeah, and I will just say, First Stop Health is extremely proud of any provider delivering care virtually, but there are a couple of key differences just kind of structurally with care delivered virtually by an in-network provider and care delivered by a true virtual care solution. And the difference is that we believe virtual care isn't just an alternative modality of access, meaning it's not just a different way to engage with the provider. It in fact represents and should be a completely different delivery structure. So we can best think about this as a comparison between direct care and networked care model, or in other words, a direct care model and a typical fee-for-service model. Our world happens to be virtual, but we are operating under a capitated payment model at risk for the success of the program, compared to a typical fee-for-service in-network physician that even when they're delivering care virtually, may still be subject to many of the unfortunate realities that make it difficult to engage with a patient. So some of those things might be doctors who are paid fee-for-service are often incentivized to spend less time with a patient, not because they want to, but because they're paid on volume, not value. Often a primary care physician that you're seeing in your network isn't actually aware of your plan design. So they don't necessarily know, if they're making recommendations, how to guide someone to an in-network, in high quality, low cost option. And lastly, we see relatively lower amounts of proactivity and follow-up. So when we think about kind of the difference between the two solutions, it's much more than just a difference in modality. It is really a difference in the delivery structure of the system and the incentives that are at play.
Absolutely. I stumbled upon a stat a couple days ago that's like 79% of doctors aren't able to figure out if a referral or a specialist care is actually in network. So it's super powerful to be able to have that follow-up. So from what you just said, it sounds like engagement and proactivity is really at the heart of a successful virtual care program. Let's talk about this for just a moment. So just being care delivered virtually isn't enough. How exactly does First Stop Health think about engagement?
So we think about behavioral science as really being at the root of the principles of our engagement strategy. Generally speaking, our model aligns very closely with the work of B.J. Fogg. And for those audience members that are unfamiliar with B.J. Fogg, he is a social scientist. And to just sort of boil down his philosophy, he believes that a patient or person really needs three things in order to make a behavior change. The first is that the motivation has to be high enough, meaning the perception of the pain or even the reward for an action has to be very high. Second, the ability to do that thing has to be there, meaning the effort that is required to complete it or the financial resources that are required to complete it needs to be low. And lastly, there needs to be prompting. A patient or a person needs to be continually reminded that something they need to do that is for their betterment needs to be done. And so that last piece is something we haven't really talked about to an extent today, but that last prompting piece, it can't just be repetitive reminders. That prompting has to be, the messaging has to be relevant and consistent and meaningful to the recipient. Much like for those of you on social media, anytime you receive an ad, it just so happens that that ad is something you might want to click on, right? So we need to make sure that our ongoing engagement campaigns, they're customized not just by client, but by patient. When we're messaging someone, we need to take into consideration their age, their gender, their locations, the clinical indications that they're suffering with, the modalities of access that they prefer to interact with, as well as the culture of the environment that they're in, their lived reality. So we spend a lot of time thinking about how to apply this behavioral science into a program that will meet the basically performance guarantees that we're promising the market.
Well, wonderful. Thank you so much to both Dr. Baughman and Elena. It looks like we might have time for about 1 or 2 questions. So let me check out the chat here. All right, we have 2 coming in. So how would you compare or contrast the effectiveness of synchronous, virtual, or critical care versus asynchronous virtual critical care?
Emily, I might be able to handle this one.
Yeah, absolutely. Take it away.
So Mick, the question, I think the question here is really about, is asynchronous care separate from synchronous care? And I think what we're learning from a practice point and what we know from a quality standpoint is that quality is going to show us our effectiveness. And that's why in our research, we use the HEDIS measures because they're standardized, and that allows us to compare care in different venues. So like telemedicine versus in-office traditional care. So I think what I hope I was highlighting throughout some of the discussion is that asynchronous care really provides positive feedback for synchronous care. And really what we can compare is telemedicine versus traditional care. And that's what we're doing in the research. That's what we've shown. So I think what I'd like to just reorient you to here is that the effectiveness is really the quality. And what we know about primary care quality is that 86% of this measure set for primary care has demonstrated that telemedicine is probably about as good, and telemedicine is tied closely with telehealth, which encompasses that asynchronous care component. And ultimately, that plays into a positive feedback loop for the quadruple aim of healthcare, which is really showing your value, which is cost, quality, patient, provider satisfaction. And that collective measure of telemedicine's effectiveness, well, we already knew it was more affordable and that patients, providers like it. And now we know that telemedicine can achieve comparable quality or comparable effectiveness.
And I would just add, in the field, I get a lot of questions around, how does just chatting with a provider over text differ from a live conversation? And I would say we are firmly of the stance that chatting with a provider over text or a nurse team or a medical care team for follow-up and ancillary questions is imperative to the process, right? You need to be able to communicate with your provider routinely. Those touch points equals trust per Dr. Baughman. However, the core of the relationship between the patient and the doctor needs to be routine live conversation. It is so important for patients to get in a virtual room with a doctor, ideally on video, so that they can really assess what is happening. And in the case of the physician, so that they can read body language and understand the context of the conversation and really get to know the patient. And if you are not prioritizing that and only using chat as a sort of ancillary support system, then you're probably doing your patients a disservice.
Thank you both so much for sharing. I think we have time for just one more. Elena, I'm going to pass this one along to you. So if a patient engages with First Stop Health virtual primary care, will they be assigned to the same virtual PCP for ongoing care, or how does that work? And just to piggyback off of that, how do you ensure the member's unique needs or conditions are remembered for future use?
Yes, great question. So the answer to your question is, our patients in primary care get to pick their primary care physician based on things like their bio, their treatment philosophy, their availability. And then they get to stay with that primary care physician for as long as they would like. They can always switch to another doctor in our practice if needed. And if a patient does come in at, say, 3 a.m. on the urgent care side, they'll get the first available provider, because if that's happening, we know the importance is speed. But all of our physicians operate off of the same electronic medical record. So regardless of who you talk to, that physician and that care team member will be aware of the sort of longitudinal relationship you have with First Stop Health, the other services that you have access to, and they'll be able to treat you appropriately.
Wonderful. Well, I think we are at time. I want to be respectful of everybody's afternoon. Thank you, Dr. Baughman and Elena. Thank you so much for joining us. And thank you to everybody who hopped on today's event. Just a reminder that we will be sending out a recording, as well as any answers to some questions that we weren't able to get to. Of course, if you have, if you'd like to get more information, request a proposal, or even get a free impact analysis, please reach out to your First Stop Health representative. If you're not sure who to reach out to, just send an email to marketing@fshealth.com and we will send you in the right direction. So thank you so much again, and I hope you all have a wonderful rest of your day.
Thanks, everybody.